Okay, thank you very much, Dr. Nardo. Yeah, and this is a fresh, hot off the presses, new name, Pivekimab. Usually it's a good thing when we have a new name, so that's what we're hoping for. And I'm very happy to present this on behalf of, as you see, many co-investigators, including many actually from Italy, as well as Spain and France, and now also open in UK. So Dr. Pamaraju spoke about the BPDCN arm. I'm going to speak about the AML combination. These are my disclosures. The study is conducted by IMGN across the globe at this point. So we don't really need to spend much time because we've already spent a ton of time and we're 1 hour behind. But HMA-VEN, as we know, gives us good response rate in the frontline setting. 70% is probably a reasonable benchmark. And we use it in the salvage setting. We use it very frequently. We add it to other things. We try our best, even post-transplant. But we know now from 3 or 4 publications, including the one from Dr. DiNardo, Decitabine 10-day Venetoclax, which was the largest prospective study, that the CR/CRi rates are somewhere between 20 and 40%. Even the 40% is probably on the upper edge of what others have seen, but they're not in the 70-80% range. And then CD123 inhibition, of course, is something that's already gotten FDA approval in BPDCN with the drug Trexaxofusp or SL401, and has also been already shown by Marina to synergize well with Aza Venetoclax, where we are seeing increased survival in the mouse and the PDX models. Now, the single agent CD123 Pivekimab did show responses, but these were more modest, 22 to 40%, kind of similar to what we see with single agent gemtuzumab, about 25-30% response rate, but the safety profile was very, very good. We did not see any CRS, we did not see early discontinuations or capillary leak, which I think are the things we were worried about with the CD123 based therapy. So this is a CD123 antibody drug conjugate. The antibody drug conjugate here is a novel class of agents called IGN that induces single-stranded DNA break, which is a little different from the most common calicheamycin as well as other agents like pyrrolobenzodiazepine or PBD that often cause double-stranded DNA break. And the preclinical data suggests that maybe single-stranded DNA break induction has less neutropenia and myelosuppression, and that is why that payload was used. So this is a single-arm study at this time. It's initially was ongoing in relapsed refractory AML. That's the data that I will show. But now it's also open for frontline AML. Primary objective is safety, and of course efficacy is also being evaluated. Efficacy is using the 2017 ELN criteria, and you see the 2 responses that are being reported. ORR, which includes MLFS basically, and then composite CR, which is everything other than the MLFS. And everybody who received therapy was evaluable for safety as well as efficacy, except for those who had not reached a end of cycle 1 yet because of early cutoff of the data. So this is very busy slide, and we spent a lot of time on optimizing the dose, which I think is important for these triplets, as you have now heard from FLT3, IDH, and others. These are not simple, and they're definitely not 1 + 1 + 1, but they can be optimized, and the reason we're spending so much effort is because they seem to improve outcomes. So here as well, we looked at different combinations, 7 days of Venetoclax, 14 days of Venetoclax, 21 days of Venetoclax, and we looked at 2 predominant doses of the Pivekimab, 0.015 and 0.045. The reason we chose those 2 doses are when we had done the single agent escalation, we had gone all the way from 0.09 to 0.45. So that's actually 10-fold higher than 0.045 that is being evaluated here. And we actually saw that once you get to the really high dose, 0.45, that's when we started seeing more issues. We had 1 case of VOD, but at the lower doses, below the 0.09, we did not see that. And in fact, the response rates were similar. This was one of those designs where we were doing expansion of multiple single-arm cohorts to get a good sense of biological efficacy and safety, something that now the FDA is very much focusing on with the Project Optimus. And then we were able to say that this dose level was clinically biologically effective without the associated VOD or toxicity. And so we chose these 2 lower dose levels 2 and 3 and did not bother with the levels 4, 5, and 6. And then the higher intensity cohorts, as we're defining them, are basically people who got 14 days of Ven or more, or received the higher dose, which is the 0.045. And I will show you why, because I think less than 14 days when we did start seeing a drop-off in the responses. So there may be a lower ceiling to the ven. We always say, can we just do 7 days, 5 days with the initial cycle, and that may not be enough. So this was the data here with the higher intensity, which is 14 days of ven or more, and the response rates are shown. The overall response rate is 59%. The CR, CRP, CRI response rate is 40%. And then there are some CRs, but not as many. Now remember, these are second and third salvage patient population, and often difficult to get full count recovery. Now, it's important to split this because a lot of the data that's been shown with HMA, ven, and salvage is in ven naive patients. So in the subset, which is small, but in those 15 patients who are ven naive, we now start seeing the composite CR rates are looking better, 53%, overall response rate 73%. Now, this population today is not really existent. When the previous studies were done in salvage, that was before HMA ven approval. Today with HMA ven approval, or with intensive chemo with ven, as we often use, these are very few and far between, and prior ven exposed is what we need to look at. Here you do see that the response rates are seen, but as has been seen with pretty much everything else with prior ven, they are lower. Now, that being said, actually among prior ven therapies that we have looked at, this is probably one of the better response rates. Even achieving 40% marrow clearance, ability to get to transplant is pretty good. Dr. Maithi from our group has published that in prior ven exposed patients, the response rate to any subsequent therapy was about 20%, with a median survival of 2.8 months. So that is a very difficult population, and we have been using this regimen for some of our patients to at least get them into a remission and to transplant. That being said, the long-term survival is still limited, but we do have people living at 8-10 months or beyond, better than the 2.5-3 months. So looking at different molecular and genetic subsets, and again, it's very hard to do this in single-arm studies and to not, because this is not a homogeneously collected population, but there were some signals that, well, it did work across the board. So ELN adverse risk, which is a mishmash of many different molecular and cytogenetic groups, didn't seem to impact the response rates per se. There's this interesting signal that we have discussed in our group, as well as with the ImmunoGen team and other investigators in FLT3. I don't know yet if this is a true signal. I don't really have a biological rationale for this, but it is something interesting that we're seeing close to 90% response in the 9 FLT3 mutated. Basically, 8 out of 9 responded, with many of them achieving a CR, CRP, CRI. And to my knowledge, most, if not all of these, had a prior FLT3 inhibitor. So could there be something here with the CD123 and FLT3? That is something we're going to try to get more patients and see, and then find a way to try to incorporate CD123, which is hard because there are many FLT3 combinations already giving excellent response rates, as you heard, the Ven, Gilt, Venetoclax quiz, and others. TP53 in the front line, I think we will see more patients with this, because obviously Aza-Ven is not doing enough, and investigators are interested to evaluate novel combinations. Aza-Ven Magro is one, but Aza-Ven CD123 could be another. Here we just had 4 and one of them responded, so really hard to make much of that. But basically response rates were seen across most molecular subsets, just kind of highlighting the splatter there overall, and we have to see more, with more patients in the front line, where this will go. I think the big difference and advantage we have found with the ImmunoGen at this point as an ADC has been the safety profile. It's been actually quite well tolerated, quite a safe drug, even compared to gemtuzumab or tagraxofusp. The main side effects we see are really 2. So one is infusion-related reactions, and that's pretty much something we see with almost every antibody or antibody-drug conjugate we've used. These are almost all grade 1 and 2. I think we saw 1 grade 3 in another dose cohort where we were doing day 1 Aza-Ven and IMGN632, but we've actually decided to just go with the IMGN on day 8. But other than with this dose, with about 50 patients, we haven't seen any grade 3. So we continue to use steroid prophylaxis, and that's not a big issue. And the second one we have seen is edema. So edema is seen. It's not capillary leak syndrome. It's not very severe. It's not life-threatening, no ICU. But we have seen patients, about 4 to 5%, who can over time, and this is usually with cumulative dosing, develop some edema. So that's something we look out for and try to manage. With the prophylaxis, the big change we've done is we've added steroids the day before and the day off, similar to what we do with obinutuzumab. This seems to have mitigated infusion-related reactions. Here you see it's down to 2% now compared to 30%. These are all grade 1, 2, but if it's lower, that's better. So this is a simple maneuver that can be done, and with that, the IR is not a problem. So currently, where are we at? The triplet is showing good activity, especially in prior ven naive patients, which is what we can compare to historical HMA ven, where the composite CR rate is about 53%. The IRRs are very manageable. It's not a big issue at all in our experience. We've treated a number of these people. Edema is something to look out for, and we do have some guidance in the protocol on when to start using diuretics and combine them for those 3 to 4% who may develop grade 2 edema over time. And then I really think frontline is where we have to go and see if there's a path for this, and the frontline study is ongoing, and hopefully we'll have updates at ASH. Thank you very much.